comes in at 6:43 p.m. Multi-vehicle collision, highway interchange, 3 confirmed critical, ETA 11 minutes. In the next 60 seconds, a trauma center activates a response that has been rehearsed hundreds of times and never runs exactly the same way twice. This is the trauma hour. The first 60 minutes after a severe injury are not a medical concept. They are an operational window. Watch a defined period during which the decisions made and the speed at which they are made directly determine whether a patient survives. The United States has a designated trauma system, a network of hospitals classified by their capability to treat severe traumatic injury. At the top of that network is the Level 1 Trauma Center. Level 1 centers are the highest designation in the American trauma system. They are required to have a trauma surgeon available in the hospital 24 hours a day, not on call, in the building. An attending physician in the trauma bay within 5 minutes of patient arrival. Immediate access to operating rooms, blood banking, anesthesia, neurosurgery, orthopedic surgery, and critical care. And a commitment to treating a minimum volume of severely injured patients each year, because volume produces the experience that produces outcomes. There are approximately 600 Level 1 trauma centers in the United States, supported by more than 2,600 Level 2 and Level 3 centers that extend trauma care into smaller cities and rural areas. Yeah, the system is designed so that any severely injured American can reach a trauma center capable of stabilizing them, by ground or by air, within a defined time frame. Activation begins before the patient arrives. The paramedic team en route transmits a pre-hospital report to the receiving trauma center. Mechanism of injury, vital signs, Glasgow Coma Scale score, suspected injuries, interventions performed, estimated time of arrival. This report does not arrive when the ambulance pulls up. It arrives 11 minutes before, and it triggers activation. Yet the trauma activation levels vary by institution, but most Level 1 centers use a tiered system. A full trauma activation, the highest level, calls the entire trauma team to the trauma bay immediately. Trauma surgeon, emergency medicine physician, anesthesiologist, trauma nurses, typically 2 to 4 with defined roles, respiratory therapist, pharmacist, radiology technician, scribe or documentation nurse, social worker or chaplain, blood bank on standby. Post operating room on standby, the trauma bay is prepared, equipment checked, warming blankets activated, blood products ordered, roles assigned. All of this happens before the ambulance doors open. The patient arrives. The next phase begins, and it is organized with military precision. The trauma team leader, typically the trauma surgeon, stands at the foot of the bed. This position is not incidental. The team leader does not touch the patient in the first minutes. They observe. They receive and they direct. Every other team member has a pre-assigned position. Left side nurse, right side nurse, airway IV access documentation, and they work simultaneously, not sequentially. The primary survey runs in the first 60 seconds. Airway. Is the airway patent? Does it need to be secured? Breathing. And is the chest rising symmetrically? Any tension pneumothorax? Circulation, blood pressure, heart rate, signs of hemorrhagic shock, disability, neurological status, GCS score, pupil response, exposure, full exposure of the patient. Every injury documented, nothing missed. Hemorrhage control is the dominant priority in penetrating and blunt trauma. Uncontrolled bleeding is the leading cause of preventable death in trauma. The trauma team works toward the goal of damage control, resuscitation, a strategy that accepts temporary physiological compromise in exchange for getting the patient to the operating room alive. Permissive hypotension, maintaining blood pressure lower than normal, reduces the pressure on an uncontrolled bleeding site and buys time for surgical control. Massive transfusion protocol, the rapid delivery of packed red blood cells, fresh frozen plasma, and platelets in a balanced ratio, replaces what is being lost and supports clotting before coagulopathy develops. The blood bank is a critical partner in the trauma hour. When massive transfusion protocol is activated, The blood bank begins releasing its product in pre-packaged coolers, each cooler containing a defined ratio of blood components, delivered to the trauma bay in sequence, as fast as the team can use them. A level 1 trauma center may transfuse 20, 30, or 40 units of blood product in a single resuscitation. The blood bank does not wait to be asked for each unit. It delivers ahead of demand. Imaging runs in parallel. A trauma whole-body CT scan, a rapid head-to-pelvis computed tomography scan, provides the trauma team with a complete anatomical picture of internal injuries in under 2 minutes. The radiology team reads the scan in real time, communicating findings to the trauma surgeon as images appear. The FAST exam, focused assessment with sonography and trauma, is performed at bedside in the trauma bay in under 3 minutes, checking for blood in the abdomen, chest, and around the heart. The surgeon is building a surgical plan before the patient leaves the trauma bay. The operating room team receives the case while resuscitation is still in progress. The scrub technician sets up the instrument field. The circulator prepares the room. The anesthesiologist reviews the pre-hospital data and the CT findings from the trauma bay. When the decision to go to the OR is made, the transition is immediate. The patient moves from trauma bay to operating room in under 4 minutes. The clock does not pause for elevator rides. In many level 1 centers, the trauma OR is adjacent to the trauma bay, a design decision made specifically to eliminate transition time. Neurosurgery runs a parallel track. A patient with a traumatic brain injury, intracranial hemorrhage, epidural hematoma, depressed skull fracture may require simultaneous neurosurgical intervention while the trauma surgeon manages abdominal hemorrhage. 2 operating rooms, 2 surgical teams, coordinated by the trauma team leader and the charge nurse. The trauma center's operational capacity allows this, but a community hospital does not. This is why the trauma system exists. Communication inside the trauma team is structured. Closed-loop communication, every order repeated back by the person receiving it, every task confirmed when completed, eliminates the ambiguity that causes errors under pressure. In a trauma bay, an unconfirmed order is an unexecuted order. The team leader states the order. The receiver repeats it. The task is done, confirmed aloud, documented. The loop is closed. The trauma scribe, a dedicated team member whose only role is documentation, records every intervention, every vital sign, every medication dose, every blood product unit with a timestamp. The trauma record is a minute-by-minute account of every decision made in the first hour. It becomes the foundation of the surgical plan, the ICU admission, the quality review, and the research data that improves the next case. Trauma centers are required by Level 1 designation to run a formal performance improvement program. Every trauma death is reviewed. Every complication is reviewed. Every case that did not meet established benchmarks is reviewed. The question is always, was this outcome preventable? If yes, what failed? And how does the system change to prevent it from failing again? The trauma center improves case by case, year by year, driven by data that most patients will never know exists. Trauma care has evolved significantly in the last 2 decades. Survival rates for injuries that were uniformly fatal in 1990 are now above 70 and 80% at high-volume Level 1 centers. Damage control surgery, massive transfusion protocols, advances in resuscitation science, and the systematic performance improvement process. Each has contributed to outcomes that were not achievable a generation ago. Back to 6:43 p.m. The ambulance pulls in, the trauma bay is ready, 12 people in position, roles assigned, blood on standby, OR on standby. The team leader stands at the foot of the bed, the doors open, the hour begins. If you want to understand how American healthcare operates at the system level, the trauma networks, the dispatch centers, the blood banks, the surge protocols, consider subscribing to Health Systems USA. And tell us in the comments, did you know trauma centers were classified by level? Have you or someone you know ever been treated at one?